So in this video, I'll be taking you through the latest developments concerning the retrial of the nurse Lucy Letby. Lucy Letby is currently standing trial on one count of attempted murder. The information provided in this video is from the live reporting taken directly from inside the courtroom. Simon Driver prosecuting is reading two written witness statements. The judge reminds the jury these written statements are agreed evidence between the prosecution and the defence. The first is from Dr. Ian Dady, who was asked to explain the process of transporting a mother in preterm labour from a Level 2 centre hospital such as the Countess of Chester to a Level 3 centre such as Arrow Park. He applies it for the scenario with Child K's mother in February 2016. Dr. Dady says sometimes it is not possible for a neonatal bed to be found at a Level 3 unit. He adds while it is recommended that a baby at less than 27 weeks gestation should be delivered at a Level 3 unit, the next best option is for the baby to be delivered locally, as there can be risks involved with transfer. The jury has already heard Child K was at 25 weeks gestation. Dr. Dady says the process of finding a suitable Level 3 centre can take 2 to 4 hours. He adds it is not uncommon for a planned transfer to be cancelled, as was the case with Child K's mother on February 15th. The second statement is from consultant Dr. Jonathan Ford. At the time in 2016, he was working as a registrar and working nights. He reviewed Child K's mother and spoke to her about the issues of extreme pregnancy. Dr. Ford said he reviewed Child K's mother the following day late on February 16th. He was called back to the labour ward on February 17th with Child K's mother in pain. At 1:52 a.m, the birth process became inevitable. Dr. Ford delivered Child K. He said the birth was uneventful. He added he had no further dealings with Child K. Dr. James Smith is called to the court. At the time in February 2016, he was a locum mid-level registrar at the Countess of Chester Hospital. He says he has an independent memory of Child K from the time. On February 16th, he was informed of the potential imminent arrival of a 25-week gestation baby at the hospital that night. He asked on-call consultant Dr. Ravi Jairam via a nurse to come to the unit once the delivery was underway. Dr. Smith explains what Dr. Jairam's recorded notes of Child K's birth are. The birth is recorded at 2:12 a.m. and the notes are written retrospectively at 4:50 a.m. It was noted for Child K, no fevers. Dr. Smith says antibiotics would be administered to Child K, a baby of this gestation, as a precaution. The note, resusc by Dr. James Smith, is mentioned. Dr. Smith says this is following a guidance for all babies, a standard resuscitation process. This involves bringing the baby to a resuscitaire, a table with a lamp and heat, to help the newborn baby with breathing and temperature. Often 2 cycles of 5 inflation breaths are required. He adds that this baby would need intubation due to the gestation, as Child K was so little. Dr. Smith adds that it's a good sign that gasps from the baby are recorded from 3 minutes. He repeats it is a good sign there are spontaneous respirations from about 4 minutes and higher than 85% oxygen saturation levels from 6 minutes. He says they are all signs of a successful resuscitation. The APGAR scores recorded for Child K, a rating out of 10 based on how well the baby is doing clinically in the minutes after birth, were not unexpected and were, quote, good. He adds the initial dusky note also recorded for Child K is nothing unusual. Dr. Smith is referred to the intubation notes, which record he successfully intubated Child K at the 3rd attempt. He says Child K was, quote, stable. He says it was a technically very difficult intubation, as Child K was small. He says there were no concerns and the consultant Dr. Ravi Jairam was present. He says although it is not documented, from memory what probably happened was he tried to intubate with a larger sized tube first, then afterwards he made sure the baby was stable in between attempts for a stable heart and breathing rate. The successful intubation was done with a smaller tube. He says child K would have been stable the whole time as Dr. Jairam was present throughout, and if there were concerns, he would have stepped in. Dr. Smith says at this point, child K would not be sedated or given pre-medication. He says that can be done for reintubation in the form of morphine and/or a muscle relaxant, but is not done for initial intubation. Dr. Smith says the intubation being done at the third attempt was for memory, something which gave no concerns. He says there was no point where there was anything concerning, that anything had gone wrong, or anything that made him feel the consultant should intubate instead. He said if there had been any sign of trauma or bleeding, he would have raised that and handed over to the consultant to intubate. He said it was, quote, a good resuscitation and child K was stable. Further clinical notes made by Dr. Jairam in relation to ventilator settings for child K are explained by Dr. Smith. An initial blood gas reading for child K was, quote, good, as were other readings recorded for a baby of child K's gestation. A blood sample for child K showed no signs of infection, Dr. Smith tells the court. Child K is noted to have good chest movement and good air entry on the clinical notes in what Dr. Smith says is a normal examination. Dr. Smith interprets Dr. Jairam's notes to say the transfer of child K to a level 3 unit Arrow Park would happen once umbilical lines, also known as central lines, are placed and x-rays are done. This would be advice given by the transport team. He says the transport team would be available to give advice over the phone. Dr. Smith recalls an event concerning child K. He says he was outside the room at the time, and when he came in, Dr. Jairam was there tending to child K. He says in the event of a sudden desaturation, doctors are trained to look for issues in a system named DOPE: displacement of the tube, obstruction of the airways, pneumothorax, equipment failure. He says Dr. Jairam disconnected the ventilator and was manually administering breaths to child K via a Neopuff breathing device. I remember coming in and saying, "What's going on?" I remember what he was doing wasn't working. He says he offered to reintubate child K. He says he performed that procedure. He says for a reintubation, a morphine bolus can be administered as a one-off before reintubation, a standard dose to make reintubation easier and for comfort. The reintubation was done on the second attempt with the larger sized tube. He says there were no signs of obstruction, equipment failure, or an issue with the pneumothorax. That would leave displacement as the issue. A note about the X-ray is presented to the court. Quote, hazy increased shadowing is present. Dr. Smith says the fact the haziness later disappeared suggests this is down to the lung surfactant and not a sign of infection. Having performed a third reintubation at about 6:10 a.m, Dr. Smith documents a summary of the events for the attention of the transport team as his final involvement. Benjamin Myers KC for Letby's defence is now asking Dr. Smith questions. Dr. Smith says a trained registrar is capable of delivering a baby in an emergency. He says for an extremely premature baby you would want a consultant present or on their way to the hospital. You would want the most experienced personnel there as soon as possible, he said. He says babies of this gestation can be born at level 2 units. He says there are many babies per year born at level 2 units and later transferred to level 3 units. He says, for instance, there could be a mother coming in off the street with a 23-week gestation baby ready to deliver. He says that could happen at any point, and the team at the level 2 unit would be equipped to handle that for later transfer to a level 3 unit. He says he had the training for that and intubated, cannulated, reintubated on the second and third time and got a UVC line into child K. Those were the key procedures that I did. He adds it was a team effort with a lot of people to help in the unit. Dr. Jairam's clinical notes are presented again. Dr. Smith says child K presents as very premature, but babies of 23 weeks and 24 weeks are resuscitated. Child K's resuscitation went, quote, very well, and a full-term baby would not need resuscitation as standard. Dr. Smith says he has dealt with many babies before and after this date of this gestation and says the resuscitation for child K, a 25-week gestation baby, went well. The initial heart rate of 60, recorded in the notes, is not a good heart rate, Dr. Smith says, but for a 25-week gestation baby left Dr. Smith encouraged, as it meant child K would not need medication to get the heart rate up. Dr. Smith says you have to take into account a 25-week gestation baby's condition, and, quote, initially dusky, floppy, no resp effort as recorded on the notes, is not anything unusual. He says a 25-week gestation baby needs a lot of help, but the resuscitation went well. Dr. Smith agrees a baby of 25-week gestation can deteriorate very quickly. He adds it is a technically difficult procedure to intubate a baby such as child K. He says it is something that can happen, as it can happen in one go or more than 3. He adds he has successfully intubated on the first attempt on a 23-week gestation baby. He says one of the reasons the first intubation might not work is the tube might not make it through the vocal cords, so a smaller sized tube would be needed. He says that is probably why he thinks a larger sized tube was used first time round. Mr. Myers asks if there is a danger in using a tube too small. Dr. Smith replies that is a scenario that has never occurred to him. He says the tube was functioning properly, as all the readings were indicating it was, including a blood gas reading taken after intubation. Mr. Myers asks if the larger tube size was used as it was optimal. Dr. Smith says the range of tube sizes used for child K, based on a calculation involving her weight, included the smaller and the larger sizes as suitable ones. He says the larger one would be used first, but that is not to say the smaller tube was inadequate. He says he would probably have asked Dr. J-Ram whether to use the larger sized tube. Mr. Myers asks about the first desaturation for child K and the dope system. He says there is no reference to a dislodged tube in Dr. J-Ram's written notes. Dr. Smith says he has no memory of seeing bloodstained secretions before re-intubation or any sign of trauma. He says if he had seen it, he would have handed it over to Dr. J-Ram, who was right there. Dr. Smith agrees there is no record saying the ET tube was checked or that it was clear from what he can see. An intensive care chart is shown for child K. Mr. Myers refers to a 94 leak reading recorded at 3:30 a.m. Dr. Smith denies this means 94% of the ventilated air is leaking. He refers to the 94% oxygen saturation for child K, and an FiO2 reading of 49 shows the tube is doing what it's supposed to. Mr. Myers asked about the second desaturation for child K around 6:15 a.m. The tube is pulled back from 6.5 centimetres to 6 centimetres in by Dr. J-Ram. Dr. Smith says that is to see if there is any effect on oxygen saturation levels. He says the levels drop further, that had not worked, therefore the tube is taken out. Dr. Smith says the tube going in at 6.5 centimetres is based on a calculation on weight and size, so the reintubation was put in at that position again. Mr. Driver for the prosecution rises to ask about APGAR scores, which child K scored 4, 9 and 9 out of 10 after 1, 5 and 10 minutes after birth. Dr. Smith says that is a standard test for all babies, no matter their gestational age. That concludes Dr. Smith's evidence. Nicholas Johnson KC prosecuting says due to witness availability, the next witness will be Dr. Barbarow, a doctor from Arrow Park. Dr. Barbarow, a consultant neonatologist, says at the time he was working at Arrow Park Hospital. Currently, he works at Liverpool Women's and Alderhay Children's Hospital. He says he only had hands-on contact with child K after the transfer to Arrow Park. Benjamin Myers KC for Letby's defence asked Dr. Barbarow to explain the difference between a consultant neonatologist and a paediatrician. Dr. Barbarow does so. A consultant neonatologist looks after babies from 22 weeks gestation up to a few months in a neonatal unit. Mr. Myers asks why it is better for a premature baby to be treated at a level 3 unit. Dr. Barbarow says such centres are more specialised, with more experienced staff to provide more intensive treatment to such babies. Mr. Myers asked if there would be a higher concentration of expertise there. Dr. Barbarow agrees. He agrees that upon arrival, child K was extremely ill and had a severe lung disease from an X-ray. The blood pressure was low and difficult to manage. He agreed child K's blood sugars were a problem and there were problems with blood clotting as well as kidney problems associated with extreme prematurity. He says he wouldn't be able to say for sure if child K would have been better if she had been born at a level 3 centre. He agrees the outcome, quote, may have been better. Mr. Myers asks about intubation. Dr. Barbrow says at the time, for extreme preterm babies, the guidance was to stabilise babies with an ET tube and surfactant, given ideally within the hour of birth. Mr. Myers asks about the uses of surfactant. He says that should be supplied as quickly as possible after intubation. Dr. Barbrow says ideally at the time it was good clinical practice, but there was no established guidance. Dr. Barbrow is asked to look at the 3:30 a.m. intensive care chart for child K on February 17th. He is asked about the leak reading. Dr. Barbrow says the 94 reading is very high and agrees it would not be an acceptable number. The VTE reading, the volume of gas, is 0.4 and low. Dr. Barbrow says those figures on their own would be of concern. He says he would look at the other figures and the presentation of the baby. He agrees those figures would be brought to his attention and agrees he would check the baby to make sure they look okay and the chest is moving. Dr. Barbrow agrees the cause of the leak could be displacement, incorrect sighting of the ET tube, or an issue with the equipment. He agrees he would check the tube so it had not been dislodged as well as its size and placement. He adds that for the smaller size ET tube, it would be unusual to see a leak reading of 94. Dr. Barbrow agrees it is theoretically possible an intubated baby could breathe for themselves, produce 94% oxygen saturation levels even with the leak. He says there has to be something else that caused a 94 leak and not just a smaller ET tube. Dr. Barbrow is asked about a mortality review for child K carried out at Arrow Park. 2 conclusions were reached. One was that her condition on arrival at Arrow Park meant her death was unavoidable. He agrees the death could have been potentially avoidable if it had been possible for child K's mother to be transported to Arrow Park before the birth. The review team's opinion was of grade 2 suboptimal care for child K. Explaining that, Dr. Barbrow says if child K was born in a level 3 centre, the outcome may have been better. There was a delay in transfer due to a number of reasons, and there were issues in stabilising child K. As part of the golden hour of best practice for a baby, there was a delay in getting IV fluids and antibiotics and a central line in. He adds there were 3 accidental extubations, which Mr. Myers says is the issue in the trial and are of some debate. He says one of the ones he was aware of was when he was present as part of the transport team. Mr. Johnson, on behalf of the prosecution, asks if deliberately moving child K's ET tube would help or hinder her. Dr. Barbrow says it would create more issues. Mr. Johnson asks if that includes death. Dr. Barbrow replies, yes. Mr. Johnson asked about the hospital panel's mortality review for child K. Dr. Barbrow said at the time he was provided different information for the reason why the transport for child K's mother was cancelled. He agrees the reason that the mother's labour was progressing was reasonable as a matter of safety. He says he was not aware the transfer at the time would have been to Preston, not Arrow Park. Dr. Barbrow said the neonatal unit did the right thing in arranging transfer as soon as possible. Mr. Johnson asked about the smaller 2mm intubation tube, which the court heard was used after the larger 2.5mm tube did not go in on the first or second time. Dr. Barbrow says that would be correct procedure. Mr. Johnson says the 94 leak reading is the same reading at 3:30 a.m. as for the oxygen saturation reading with the VTE reading of 0.4, the same as the inspiratory time reading also on the chart for 3:30 a.m. Asked which is the most important reading for the baby, Dr. Barbrow says firstly the baby's presentation is the most important. He adds the most important reading on the chart is the oxygen saturation reading. He adds that is a snapshot at that moment in time. Dr. Ravi Jairam is the next witness to be called to give evidence. Dr. Jairam is a consultant paediatrician at the Countess of Chester Hospital. He says he started in the field of paediatrics in February 1992. Mr. Johnson says a number of witness statements Dr. Jairam has made have been in the case of child K. He says independently he has a memory of certain events from the night of February 16th to 17th, 2016. He explains to the court the on-call system for consultants at the hospital. He says there is an obligation for on-call consultants to be available at the hospital within half an hour, and he lived within that area. He says he cannot remember, but would probably have been aware on February 16th that there was a possibility of child K's imminent birth that night. He says he would have been called that night by Dr. Smith to attend the hospital at the time child K was being born. Dr. Jairam explains the intubation process. He says it is a less urgent situation in this case as child K's readings were normal. He says it is important with doctors in training that they get experience, but the child's safety is important. He says in this situation with child K's readings, that meant Dr. Smith could carry out the intubation. If there was difficulty getting oxygen in, then Dr. Jairam says he would have taken over. He says it doesn't really matter what size the intubation tube is, as long as it functions as it should. Dr. Jairam explains the blood gas readings for child K at this stage would be seen as acceptable. Mr. Johnson says a blood sample from child K was taken to a lab and 5 days later showed there was no sign of infection for the baby girl, which he says is a fact. Dr. Jairam explains the process of morphine administration, which was a continuous infusion. He adds child K was pink, tone good. Presenting as pink suggested oxygen saturation levels were in the 90s. A capillary refill test, a piece in the jigsaw, showed good capillary refill and meant Dr. Jairam was happy with her circulation. Dr. Jairam says with child K being born in a level 2 centre, the plan was to stabilise child K first before arranging transfer to a level 3 centre. The plan was to put in arterial and central lines and conduct X-rays to check the positioning of those lines. Dr. Jairam is asked about the APGAR scores, which he says are good, 9 out of 10 by 5 minutes after birth. Mr. Johnson says Dr. Jairam's notes are written retrospectively. A 4-minute video of how a resuscitator is operated is shown to the court. Dr. Jairam confirms the equipment used at the neonatal unit in 2016 was similar to the equipment demonstrated in the video. That concludes today's proceedings.